All right, we're going to go ahead and get started. Welcome to today's Recovery Summit presentation, a substance use disorder, health equity report card, and landscape analysis of SUD treatment resources in Port Huron, Michigan. This webinar is part of a series hosted annually by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded on the CMH YouTube channel for future reference. Please feel free to use the chat box for all questions or comments. Our presenters will be answering questions as time allows. Continuing education credits are offered for today's presentation. If you are requesting professional credits, you must remain on the webinar the entire time and complete the survey at the end of the presentation to receive credit. And now I'd like to turn it over to our presenters. Welcome.
Thank you for that introduction, Christy. So I am Ken Huvelman. We'll be presenting with Corinne Campbell, Heatherlyn Uphold, and Blair Warren throughout this presentation. This is our discussion on our substance use disorder health equity report card, and then some of our process for a landscape analysis of SUD treatment resources here in Port Huron. Going on to the next would be just a quick introduction of this research team. So our shared collaborative team had multiple principal investigators, co-investigators, staff, trainees, interns, and a large team to help put this information together. What we did for this, our project goals, and the project itself was actually funded through a small grant through Michigan State University's Addiction Consortium on Research and Education Network, or ACORN. This research focused on three of their pillars, which involved community engagement, clinical care, and research. With community engagement at the center of the work, we explored some of the depth of services for substance use disorder, or SUD. That's that SUD acronym you see. And what we had here in the Port Huron community, looking at providers, services, strengths, gaps, and leveraging the team's relationship with the St. Clair County Community Services Coordinating Body. We used our services to research involving a community-led landscape analysis of those resources, and then co-developed the SUD-Health Equity Report Card, or SUD HERC, as we call it. The focus of the project was to really help truly identify what services are available here in St. Clair County, how health inequities are impacting our community, with the overarching goal of this project to be able to help guide future discussions and create plans to begin to fill in the gaps and address some of these health disparities in our community. We looked at choosing Port Huron specifically, as you can see on our next slide here. We have a mostly rural community. The county of St. Clair is primarily rural. You can see that there is about 20% of folks who do live within the Port Huron city proper. The vast majority, almost 130,000 people, being outside in St. Clair County as a whole. Some of the demographics of our community: it is a primarily white county with a small population of people of color. Then moving into Port Huron in a more urban setting, there is a greater population of people of color, with the primarily being people of Black, African American, Hispanic, Latino, but predominantly a white community. Why we chose Port Huron and St. Clair County, you can see on the next slide here, is just some of the disparities and issues within that. St. Clair County in Port Huron in general, we come in with a median household income nearly 30% below the state median income. This is an area with high poverty rates, and as we know, poverty rates, income levels directly impact health outcomes. We also looked at there was an insufficient availability of behavioral health care and treatment for substance use disorder. There was some things that said we had good treatment on the grounds, and being in the community, it kind of said, well, what do they mean by treatment? What does that look like? So we kind of wanted to be able to take that deeper look and start to see. What we did also see is we have higher than average patient to provider ratios here in St. Clair County. One of those primarily being in psychiatric and behavioral health care. Another area where we have a significant disparity would be also in our OBGYN care. That rural geography also comes into play with transportation and access. If you live in a community that doesn't have mass transit or isn't serviced by bus lines, public transportation, or other means of getting around, you become wholly dependent on your own personal private automobiles. Another issue that we saw here in Port Huron that we thought was primarily a good reason for it to be an area of focus is St. Clair County and Port Huron rank third for opioid prescription rates and non-fatal overdoses across the state of Michigan. So we have a large number of opiates available, accessible, and being prescribed, and that non-surprisingly does lead to, increased rates for non-fatal overdose. Additionally, as a county, St. Clair County is 8th highest in fatal overdoses for the state of Michigan, which is not one of the things you want to be known for as a top 10 county. So going into our next here, I can see we started to look at the landscape analysis and that purpose. We wanted to delineate what do we actually have. You can say that you have a lot of treatment services. You can say that you have enough counseling. You can say that it's there, but do you? What do you actually have? So we decided to look at creating a map to visualize some of the distance of treatment to see if some of those common barriers existed. Then we wanted to know is there a wrong front door, or is there a place where, yes, you have an office, but I can't walk into that office and actually get started. So you might have one in my community, but the one I need to go to first is 20 miles away in another area. So is availability for sign up or intake available at each? Then taking a look at that landscape analysis, pulled apart kind of the setting types. What kind of places are these services available in? Are they home-based? Are they in a residential? Is this something that's only available in an outpatient clinic or only available in a long-term care setting? Do I have to go to jail to get treatment? How do I get it? Where is this service being provided at? And then looking at what specific services do you provide there? It's going to a restaurant without knowing what food is on the menu and hoping that they're going to have what you want. If I needed this, can I go here to get that? And then looking at what population served. Were there gaps based on your age or your gender, or any of those things that made it more difficult for you to have access to services just because of who you are or how old you were? So that kind of drove the purpose for this. And as you can see, as we dig into it, looking at the next one, you can look at what we saw is where we're at in that progress is we had to kind of sort out how to figure out we're going to gather this information. So we needed to create a survey, and it was through our community services coordinating body. We have a substance use prevention, treatment, and recovery work group that I am a chair of. We recognize that we don't have a good service directory. If you needed to know where services were, you needed to know someone else who knew where services were. The yellow pages disappeared a while ago. Google is not always accurate. Community resource databases aren't always up to date. And we needed to help that work group kind of establish this resource directory. So it was kind of dual-fold. We were going to be able to take this look while also filling a community need to create a resource directory. When developing a survey and organizing it, we had to create some standards for setting types. What we identified for setting types were those identified through the Centers for Medicare and Medicaid Services. If you are a biller or a person who provides services, you become a little bit more aware of service codes in different types of places you can provide it. So we needed to form, what do you call it? Then it was service types. What is the services that a agency can provide? What we used for that was the Region 10 PIHP's authorized services. So what does our primary public funder for services say that people can provide? What would they pay someone back for? What would they call it? How would they identify it? So then we kind of formulated how we were going to go through and complete that landscape analysis. Looking at the next one kind of shows some of the processes on this slide. We then realized that there's a lot of different setting types. If you're in an ambulance, it matters if you were in the air, on water, or on land. So wait a minute. Do we need to have all of these services? Do we need to know all of these setting types? And if we have 50, 53, 54 different specific services, and I want to ask someone to fill out 54 different surveys, this will die in an inbox. This will be looked at. People will say that's cool, but no thanks, I'm not filling that out. So we used kind of a collaborative process. We realized that we had myself as a community leader, as a service provider, that I viewed services in setting types one way. Then looking at Blair or Heatherlyn or some of the other members of the team who are either academic or they work in public health or they have a different perspective, recognize that, wait a minute, we need to collaborate on how we should break these 53 down into something that's a little more digestible. We used Google Jamboards, which is gone now, actually. It's actually disappearing and shifting, but it allowed for kind of a post-it note, hey, lump this, organize this how you see it, and create what you think works. So then we were able to take those 50 plus and knock it down to about 15 different setting types that we were able to come to agreement. And that was, again, to just make sure that you had some of that uh, collaboration, making sure that it wasn't one person saying it should be like this and someone else saying I see it that way. So it worked to collaborate things out that way and avoid any of those biases from one perspective. As you can see on the next one, we started to begin to digest the information we got. So after we sent out those surveys, we had to identify who we sent the surveys to. What we chose to be our defining marker was an organization had to be licensed by the state of Michigan as a SUD provider, either prevention, residential, SARF, CATE, or any of the licenses. Then you realize that some organizations like Community Mental Health doesn't hold a license, so that's not there. So we also included anyone that was a contract provider for Region 10 PIHP. So we took licensed facilities and contract providers with the public funder. And then we also looked at any organization that was credentialed or certified with recovery, with the Michigan Association of Recovery Residences. We were able to send out and recognize 13 different unique locations, 7 of 11 parent organizations. We found 11 providers that fit those criteria. We had about 64% of people responded to those surveys, and it became some of the barriers and things we looked at is, what's the best method to, send out a survey and make sure that it comes back collected. So we found 13 unique locations for service provided here in St. Clair County, with 10 of those being able to provide intakes or signups. So showing that very likely you don't have to go to multiple locations just to get started for services. You can go to the same place for intake that you will go for your treatment, which just, it makes things easier. And with a population who's already in crisis or struggling with, situations, it's a significant factor. What we saw is we have a large number of services for adults. As you can see, adults of any age, 156 unique service and setting types that exist, 11 different locations provided for those adults. As you can start to see, the ones that are identified in yellow are showing that maybe these are an area of concern or an area where there's a gap. Limited services for children. If you are a child, there are 2 locations that you can go to. And within those 2 locations, there are only 8 distinct services that are provided in there. Same kind of thing for parents. You can see co-parenting or adult females and adult males with children. There are no services specifically designated for men only. And it raises some of those questions. Are there specific services that would be benefited for men only? In the adult females, there was a small section of those that existed as well. So we saw an adult, you're very likely to have services. As we start to become specialized and look a little bit more, such as minors or adolescents, we start to recognize some lacking areas. If you go to the next one, you can see that we looked at gaps in service types. So this was some of the things that we recognized and saw that, okay, we have none or limited areas of. And as you can see on these, some of the things that we lacked in services was a day treatment program or partial hospitalization, which is a service type of 20 or more hours of clinical services in a week, but they still aren't staying residentially. There were no in-county medication-assisted treatment providers that prescribed methadone. We had few that provided pregnant and postpartum services. There were some unique locations. But again, not necessarily a large amount of services to help our pregnant postpartum women. Then there's the large block of red towards the bottom that you can see, which is our residential treatment services. There are no providers that provide residential treatment services within the confines of St. Clair County. And there are also no one in St. Clair County that provides withdrawal management or what's known as detox services in our county as well. So you can see some significant gaps that show up there. Another one that is interesting and many people might not recognize is child sitting services. Do you have services that can be provided for a mother or a father while they are in the services? Is there a program that involves mom can come, dad can go to outpatient or residential, and somewhere their kids can be cared for, taken care of while they're going to services? And that was identified as a gap. And it is a reimbursable service. It is something that does have a billable code and could be reimbursed for. We just saw that it wasn't there. You can also see that there was a couple smaller ones. We have one IOP program. That's 9 to 19 hours of clinical treatment in a week, still at an outpatient level. And that was something that's, we don't have a large number of. Also the same with family psychotherapy. Do we have whole family services? Others that we kind of can see, so you see the very bottom there, you see the yellow in the left-hand location column, but then in that right, services. So we have syringe service programs. We had 2 locations that were identified for syringe exchanges, but you can notice that they have a large number of services within those 2 locations. So perhaps that need is met. You may not need 25 different locations if you have 2 that are effective in providing a large array of services. So that's what we saw for gaps in service types. Going to the next one, we looked at gaps in setting types. So again, you can have services, but where are they and how can I get to them? Same thing we saw here. There was a large amount of in-home and telehealth services. This is not to be surprising after 2020 and things like Zoom, which we're on now, became basically normal. To have business meetings, to have webinars, to have clinical services through telehealth has just become common. So we had a number of providers that was providing this, which is great because that is a huge benefit to accessibility. Some of the other ones we saw were, our jail. Our jail has a few unique locations. And no, we don't have 3 jails or correctional facilities. We have 3 service providers that responded that are providing 8 separate services within our jail. So you can recognize that people that are incarcerated are being provided a service, which is a good thing. It's how rehabilitation happens while incarcerated. Then we have a large number of some of the red ones. Some of those, not to be surprising, we don't have a military treatment facility. We don't have a large military population housed here. We don't have a tribal or Indian health center. And again, in part, we have a very small tribal community in our area. Some things, though, is we don't have any organizations that are specifically providing a school-based service. There are communities that have in-school providers that are in the school for an alternative to suspension or expulsion, as there's a program within. We had a recovery high school start for a handful of months before it had to fold due to low admission rates. We have no shelter-based services, which is another barrier. This is another high-risk, at-risk population for substance use and co-occurring disorders, but we're not necessarily providing services at this time directly in those shelters. Another one that was also on there is kind of your inpatient mental health or residential facilities. We don't have the inpatient residential, the withdrawal management, and some of those that we don't see. So that was kind of what we were able to pull from that landscape analysis, looking at those different areas of concern for age, by service, and by setting. And as you'll see on the next one, there's a little map that shows part of our concern. What we have here is a map of where those 13 separate locations are. If you live in Port Huron, you have a large number of services in your area. If you live outside of Port Huron, you don't. This becomes a significant gap just in access. As you can see in that area, there's a concentration there. Then you have the community mental health satellite locations, 2 in Marine City and 1 in KPAC. If you are anywhere inside that triangle of St. Clair County, you are having to travel to services unless telehealth's available or telehealth's even an option. As you can see, we talk about that a little bit more in our summary of some of the things for the landscape analysis on this next one. If you're not in Port Huron, which we recognized 82% of the population is not in the city of Port Huron. So 82% of people in St. Clair County are traveling to enter treatment. Of those, you run into that part that also means a car is required. So do we have public transportation outside of Port Huron to assist these people with coming in? I don't know. We'll have to wait and hear what Heatherlyn and Blair tell us. We have very few services tailored for specific populations. As I mentioned, the pregnant, postpartum, children, fathers, and families. Very little access to medication-assisted treatment or medications for opioid use disorder. Significantly no providers providing methadone, and a limited number of providers. I believe it was 4 locations provide either buprenorphine or the naltrexone. And those 4 locations are, to an extent, your CMHs that provide those. It is a little bit off. There are primary care physicians that can prescribe that medication, but they're a very hard group to nail down and get to complete a survey on a very specific, do you provide a medication? We would have had to do that would be surveying every single medical license holder that could prescribe in our county to see if they do it. Is it worth doing? Yes, I believe so, but within the scope of this project and with the funds we had available, it was outside of what we could do. Limited setting options. Like it was mentioned, we have a large amount of services in our jail. So if you do need to go on to some treatment level, you can commit a crime and get services. It's not the recommendation to go to jail to get outpatient treatment, but you can. So recognize we have outpatient. We don't have some of those higher levels of care, withdrawal management, an opioid treatment program, inpatient, crisis care, engagement centers. Some of these things are missing, and that's that full continuum. If I start my journey with withdrawal management or detox, and then I go to the next one, and then I go to the next one, and then I go to the next one, if you can stay consistent and in a continuum, sometimes with a single provider, you have that ease of transition. You go from one to the next, and it works. We have that kind of, it's pieced together, and some of it is you go somewhere else, and when you come back, we'll work on the next step. One of the other things that we did find with this landscapes analysis, there was a significant benefit to having me on the to having someone like me on the team, right? Not just Ken, but someone that can be in the community. So if we had asked someone to do this, so Heatherlyn is in Fenton area. Blair lives somewhere else. We had a team member that is out of Atlanta, which can be done. Our surveys were all done digitally. They were by email. So you can do these landscape analysis very remotely, very convenient, super helpful. But if you don't have someone in the community to help know just enough, a little bit more like, well, yeah, they do this, but it's actually like that. Or, hey, they might not be on this registry, but they're over here doing that one. So having a local community provider or someone who's knowledgeable about the resources in the community is a significant factor when kind of developing a team to do a landscape analysis like that. Going into our next section, I believe this is where I get to hand it over to Blair and Heatherlyn.
You absolutely do. Wonderful job, Ken. And I just want to underscore really the importance of having that local voice and voices as a part of this work. Just like Ken said, yep, you can do it. You could do it remotely, but it's just not the same. And even I would add to that, being able to pick up the phone and say, oh, I know who that is. Let me just give them a call, and we can get that information. We can get that form filled in. I think just is critical on so many different levels. So Ken mentioned, I'm Heatherlyn Uphold. I'm an assistant professor at MSU in Flint. I do live in the Fenton area, but Port Huron and St. Clair County holds such an important part in my heart because it's actually where my handsome redhead and I got engaged. So right under the bridge. I'm not going to tell you how long ago it was because it was a number of years. But nonetheless, I'm so grateful to be a part of this work and supporting the community and the wonderful efforts that everyone has been doing to support substance use disorder efforts in Port Huron and St. Clair County. But on the docket next is for us to talk about our substance use disorder health equity report card. It's a mouthful, I know, but we call it the SUD HERC. And what it does is it helps us to communicate disparities in health and SUD data by location. So we're able to understand differences between geographic groups like Port Huron and St. Clair County. And the reason that this is important is it supports existing prevention and intervention efforts like what Ken has been talking about, but it also provides us with a wonderful foundation for data-driven discussion, for policy change and recommendations, and to determine funding priorities and a wide range of other activities. But this larger picture, and this is a little bit of a soapbox, so bear with me, is that I want to just really say how important it is to make data and information more accessible and more usable for everyone, especially our community leaders and our local residents. I don't know if you've ever tried to go looking for, a particular, that this is the truth. You just need to find the place on the website where it says this. And so you dig and you go to the census, you go to where these other places, and it's more work than worth. And so what we're doing is we're addressing that by making information, making data more accessible and more usable because we view information as an additional determinant of health. So stepping off my soapbox, and I will turn it over to Blair.
Yeah, so basically we found data from 7 sources, including the Census, CDC, and others. And from there, we found 21 indicators, including drug overdose deaths, educational level, drug-related arrests, and others. For the analysis, we calculate a very simple disparity ratio, which is the outcome or rate of one group divided by the outcome or rate for the second group. What our analysis tells us is that the higher or bigger the number, the higher the difference or disparity between groups. It's also important to note that the disparity ratio shows us differences between groups and not how the population is doing overall. And then going into the next part of the analysis was to turn those disparity ratios into letter grades. Prior to creating the SUD HERC, we looked at other health equity report cards for communities across the country to evaluate how their grading was calculated. So we based the SUD HERC's grading scheme on a model from New Mexico. This scale contains letter grades from A to F, with A meaning no disparity and F meaning a critical disparity that requires immediate intervention. So now we can jump on into the SUD HERC itself. And if you'd like to explore the SUD HERC, on your own computer device, you can scan the QR code here or open up tinyurl.com/SUD-HERC.
And I did just throw that into the chat as well. So if you want to just click the link, you can do that as well.
Thank you, Ken. Yeah. And then on the left, there's a download PDF button. So you can click that and it'll take you to a separate tab where you can view the whole SUD HERC in one PDF. And we start, with a introduction page, and then we go into demographics, showing race and ethnicity breakdown, as well as age, some general information. And then we go into fast facts, which is basically pulling key findings from the HERC, and, kind of giving it more context and explaining it further.
And this, something, I'm just going to take us back to this piece because the other reason that this is important is that not everyone is familiar with Port Huron and St. Clair County. So it's really helpful to not only situate the community in everyone's mind, like, oh, in the mitten, that's where you are, but also from a data perspective in a breakdown of race, ethnicity, and age, just in case folks aren't, this isn't the city that they're familiar with, or they don't have the community voice to provide that background for them. So just another sort of Easter egg, I guess, that we included in the report card to make it a bit more usable for folks. I'll talk briefly about this. You might be familiar with the MySUV or the Michigan Substance Use Vulnerability Index score. We'll go into what this is and the data, but it is included in the report card. And then Blair mentioned those 3 different categories that the data is broken up into. The first category is health services and access. This includes sorry about that. This includes things like households with no vehicle, households without internet, population within 30-minute drive to a hospital. And you can see overall we're doing okay. Pretty much the groups are pretty similar when it comes to disparities. I will just, let me zoom in just a tick so you can see it. You see these 2 boxes here that are yellow. This one has an asterisk. And that is telling us, you can see it's listed down here, that an asterisk indicates that St. Clair County faces worse outcomes. And in this case, versus Port Huron. So we're seeing that in this case, St. Clair County faces worse outcomes. In this case, Port Huron residents face worse outcomes. On the next category is socioeconomic status. Let me just back this up just a tick. You can see there are some mainly A's. We've got a C, couple B's, and an F. We'll go into that data when we return to the PowerPoint slides and we'll talk about it. The grading scale is listed at the bottom of each of these slides, just in case a community partner wants to just come in and grab the entire page. And that reference is included because really that's one of the other things that we included in the report card is so that folks could just kind of copy and paste directly from it and use it in grant proposals, annual reports, or other communications. This is the final category. This is substance use. And here we have variables like drug-related arrests, opioid prescription units, overdose deaths. Again, we've got this F. We'll talk about that. And then finally, we've got our glossary.
Yeah, so I'll go into that. We also we want to highlight this glossary. It provides 2 definitions for each term. One that is how we would explain it between each other, just in normal conversation, and one that was pulled from a credible source that could be used in a formal communication, such as a grant proposal, for example. So you just get some options there. Just provides more context when you're looking at the SUD HERC.
Thanks, Blair. Taking us back to our slides here. Hopefully we did that. And you're seeing the right stuff and not my notes. What we're seeing here, so we kind of did a teaser with looking at that data, and perhaps you're looking at it if you've got the SUD HERC pulled up. But we do want to elevate some things that you may be familiar with. We do see that St. Clair County residents are 4.5 times more likely to die from an overdose versus Port Huron residents. So that's that grade F, a critical disparity. Grade C, this is where we're seeing that St. Clair County residents are twice as likely to live more than a 15-minute drive from a syringe service program compared to Port Huron residents. If you're reflecting back to that map that Ken showed us, it should resonate. And then we see Port Huron residents are actually twice as likely to be without a vehicle and to live in poverty versus St. Clair County residents. We do want to note, and Blair mentioned this, that the letter grades are telling us differences. They're showing us disparities between groups, not necessarily the overall outcome. The next piece is to talk about the MySUV. So this is a measure of vulnerability to adverse substance use outcomes. It's not telling us good or bad counties, but really what it's showing us is a comparison between counties. So the MySUV is made up of 8 variables that are grouped into 3 different categories. You can see those 3 categories on the slide. That begins with substance use burden. And this includes things like opioid prescription units, overdose deaths, non-fatal overdose ED visits. The second category includes substance use resources. This is where we see the percent of population within a 30-minute drive of a publicly funded treatment center, as well as percent of population within a 15-minute drive from a syringe service program. And the last category is social vulnerability. This is where we're looking at the percent of households without broadband internet access, percentage of population within a 15-minute drive to the pharmacy, as well as incorporating the social vulnerability index itself in this category. But we want to know the data. So let's look at the data. So out of 83 counties across Michigan, we see that St. Clair County is kind of in the middle of the pack when we're looking at the total MySUVI. So we're 46th out of 83. But then when we look at the breakdown of those three categories, substance use burden, St. Clair County ranks 11th. So substance use burden includes things like opioid prescription units, overdose deaths, non-fatal overdose ED visits. The next category includes substance use resources. This is where St. Clair County ranks 19th. Substance use resources, recall that this is that drive time. So within a 30-minute drive of a publicly funded treatment center or within a 15-minute drive from a syringe service program. And then finally, for social vulnerability, St. Clair County ranks 59th. So this includes things like percent of households without broadband, and then percentage of population within a 15-minute drive of a pharmacy. And what you can find the MySUVI. There's a great there's a data dashboard on the what is it, Michigan.gov website. But we do want to just remind you that the MySUVI should not be used alone for decision making. It's so important to have a broader understanding of the data about the community, the experiences of community members. Ken mentioned that. I don't think I can emphasize it enough, but so important to take all of these things into account when making program decisions, funding decisions, or policy recommendations. With that, I'll give the baton back over to Ken.
It goes to me. Oh, I thought we went over to Claire. See, that's what I get for thinking. So looking at some of these parts, you see what we gathered from all of it. And as Heatherland kind of pointed to, some of the things we see in that landscape analysis clearly stick out in our SUD HERC. You're at greater risk for death in the county than you are in Port Huron. Yes, you're further away from treatment resources. Even in a hospital setting, you're further away from a hospital. So your crisis, your emergency, it takes longer to get to. Are there ways to prevent this? Does this mean you need to provide harm reduction methods out into those areas? You need to make sure that they're more accessible. Being further to drive, and then you see one that is almost beneficial. A large number of services being provided in Port Huron is a benefit because the people of Port Huron are more likely to be in poverty and lack a vehicle. So you need to have services that they can access without having access to a car. So it almost becomes, okay, now there's almost a benefit to that. So it allows you to take that landscape analysis, what do we have, and then some of these health equities, and work to create it apart. We also identify that you see these few tailored services for pregnant postpartum, children's fathers, and then we recognize that we have nearly twice as many single households in St. Clair County versus Port Huron. So then we have, okay, wait a minute, we have a large number of parents that don't have potentially childcare, or where the children can become a barrier to access, and we might not have a service that allows for a mother or a father to enter services with their child. Or while they're receiving services in an outpatient care, they've got to bring their 3-year-old to the intake or the session with them, and that just doesn't work. So recognizing that we need some population-specific support. And then one of the things that sparked me to raise this to this group and bring it was our substance use. Which one was it? Was the third part. It's not the burden, it's the resource. That really, we're doing great. We're 53rd out of 93 counties, somewhere in there. So we're in the bottom third. That looked really good. But when you start to look at some of these things, you see treatment facility access. So we have a large number of treatment facilities. Valid. We found 13 of them. But it's kind of like hosting Thanksgiving dinner and not making sure you know what anyone's bringing. So you have the most fabulous plan. It's going to work. Everybody's going to bring food. You show up to Thanksgiving dinner, you're at grandma's house, and 18 people brought mashed potatoes and no one packed a turkey. Technically, you have food. Everyone will eat. It will be there. You're fine. No big deal. Well, when you look at it at that black and white part, that if it exists, it's good. Or it exists, it fits a need. that's what started to show that, wait a minute. And that was some of those I looked at and I said, we have treatment access. Well, yes, but we only have limited kinds. The other is you see that our score gets reduced because of our syringe service program. According to the state's MySUVI, we have 5 of them, which what we do is not have 5 of them. We have one that's operated by our local health department that goes to 3 or 4 separate locations to provide some of those syringe services. So that may be one day a month you can get that service at one place. So it's not really as accessible as it seems, where you're like, wow, this county with 150,000 people has a syringe service program for every 30,000. So taking that look that you need to use some of these disparities that said, yes, you're close to it, but is it useful? Yes, it's useful, but are you close to it? Or does that help? So using these 2 tools together was really powerful to help paint a more accurate picture of what's going on. And then as you see on the next slide here, with some of the stuff that our group is continuing to work on. So we've worked to complete this. We continue to work to, create a good usable map to share with the community. Part of this was also to create a model that maybe other communities could be using, or that this could then be expanded beyond St. Clair County and taking this, this workable project and then expanding it to a greater area to get, just a bigger landscape. It also looked at, understanding and better navigating service codes to make sure that we have those right, or that what we call it is the same as what they call it in another region, or that there's consistent language amongst organizations. We are working with the Michigan Institute for Clinical and Health Research to promote academic and community engagement. That's a dissemination grant that we were provided to work to make sure that this information is out there. We are also working to put together a training, a small one-day training that would help to use other organizations or community stakeholders to develop something like this for other areas. The team also works on a PEPI disc, Port Huron inflammation trial, which works with pregnant postpartum women and enhanced women's specialty services. We're going to recognize opioid service gaps. I'm able to sit with our county to help recognize what may be beneficial for our opioid settlement money. The county of St. Clair County has received over $13 million to utilize on opiate settlement funding, and using these kind of things to advise what makes sense. Then working with ways with the health department and others to assist with the maternal infant health program, which has a large number of pregnant women who are involved with substance use. It's a primary concern of that population, and working on ways to make sure that that population is sorted. And then we also recognize the need for potential fatherhood programming here in Port Huron. So that's some of the stuff that we're able to create and come up with through this, and then able to, work and hope to continue to grow and take further. So with that, I want to thank you. Our contact info is here on the next slide. You can reach me through PCC, and then everyone else that's special and gets to yell "Go Green" every day, and gets to get followed up with someone yelling "Go White," because that's the best school in our state. And I'm just going to say that and probably anger everyone who wears blue and yellow. So I guess at this point, hey, Corinne, there you are. We can jump in and see if there's any questions that we can field. I didn't see any in the chat so far, so if you did have some, you can throw any of those questions, comments, or concerns into that.
But we can talk too, it really was amazing how, kind of with this project, there were 2 things happening. You guys had the landscape analysis going, and then with the SUD HERC that was being created, and then all of a sudden to sit in that meeting and to just watch everything, come in and just blend and confirm what we were seeing on both sides was really powerful, disheartening, encouraging. It was kind of all of the feels all at once.
Yes, to be able to kind of see like how one spoke to the other and the other said, yes, that, what you see there is having an impact. I don't want to call it proof. I don't know if it's a hard enough science that way, but where it starts to help show that, yes, you can't ever causation and correlation things, but to recognize that, okay, this is probably part of the concern. What we hope for also is, again, to engage stakeholders. None of us here at this table, I don't believe, are building a treatment facility. But it may use this landscape analysis to go, if you build it, here's where you should put it. Or, hey, here's a community that is just not being served. And as Tanya's kind of put in there, yes, if you live in a rural area, that's great. You've got a gas station, maybe a tanning salon and a Little Caesars. If you're lucky, you got a stoplight or two. And that's kind of it. And beyond that, you're stuck with traveling. For Laura's question for the gap areas, I would say yes. There's always discussion and plans. The county is working to see what they can do with some of the settlement dollars so that those can be used effectively. Things like this tool are hopeful to be, again, as I said, to advise that. I can say other organizations are working on pregnant and postpartum services. And there's been a large number of discussion at the Substance Use Prevention Treatment and Recovery Work Group about these gaps, and then what we can do to fill them. I know some organizations have looked at creating engagement centers. There's been discussions on how to increase it. So there are always ongoing desires and discussions for those gaps and to fill them. A lot of this was just very much to show them they are here and make it seen. So for Alyssa's, Sacred Heart is still operating in Memphis. Memphis is in Macomb County. So where Sacred Heart falls, it is outside of St. Clair County. So it is not included in the St. Clair County map for that reason. But yes, Sacred Heart in their residential facility is still active and serving people. Outreach in the rural areas. So again, as the one in Port Huron, everyone else goes, Ken, yeah, what are you doing for the people there? Yes, there is some outreach. One of the programs was done by Flint Odyssey House, Port Huron Odyssey House. They placed a naloxone distribution box at almost all of the libraries in St. Clair County. So if your community has a library branch, which there's 13 of them, and they do hit the CAPEX, the Yales, and all the others, there are access to naloxone. There are naloxone trainings that go on in those communities to help discuss the risks of overdose and to help prevent some of those deaths, because 4.5 times more likely is a large number. Telehealth services has been expanded. I do believe Sacred Heart had received funding for telehealth expansion from the state. I know Professional Counseling Center, where I currently work, we are working to expand our telehealth reach. It is a common goal of many organizations. You can get telehealth through community mental health. So those are some of the ways that SUD Services is working. But there is still a benefit to potentially having an in-person and local center where someone can go. There are benefits to the accessibility of Zoom, and there are others that feel the benefit to having an office to go into. So those are some of the outreach efforts. I know the health department has expanded their, adolescent health clinics to help increase those those are staffed with a social worker in Clay Algonac schools, as well as, and I'm going to get it wrong and Liz will yell at me, I believe Yale is the other one that has placed an adolescent health center in there. So it's working to continue to reach those outlying more rural areas, because we know the concern is there.
Oh, Karen, you're saying something marvelous.
I apologize if I missed this before, but I wanted to chime in that 2 of our other projects that we're working on focus on building an online web-based application to provide gap services for people who cannot immediately get treatment, who are in substance use disorder crisis. And we're also have a lot of things, irons in the fire, that we're trying to do to extend this work, particularly in the domain of dissemination. We're doing a training session January, February about how to help other communities implement these tools. And part of that is getting together a website for distribution of the data that we have, particularly for St. Clair County, all of the stakeholders, not just people with substance use disorders, treatment providers, emergency service providers, politicians, everyone, to be able to go onto this website and use the map that we showed you a screenshot of earlier to choose what do they want to see in terms of where services are and what services are. Do they want to search by age? Do they want to serve by the type of service or the setting? Do they want to serve by the search the map by the type of substance use disorders or whatever it is, to be able to filter out and see, you know, if I'm a client and I need services, where in the county can I go? If I'm a service provider, are my services represented here? Because we didn't have a full response to our survey. And, you know, we want people to see that, you know, if you have services, people know where they are. You need to report them through this resource directory so that we can keep this map updated regularly. If you're a politician who is trying to advocate for funding for, you know, or laws, or for anything for your county or, you know, city, whatever it is, the municipality is, they could be able to go and use that map to then show proof and demonstration. And the biggest thing that we hope to do with dissemination is to address the stigma and push back against the, you know, not in my backyard. Yeah, it's a substance use problem, but it's people up from the outside coming in, so this shouldn't be my problem, because they have been many efforts in Port Huron and St. Clair County that Ken can speak to better than me about people concerned about these issues, trying to establish services and resources and getting their efforts shut down because they don't want it in their community.
Absolutely. You know, and continued acceptance and stigma is a major. If you build it and you don't have buy-in from your community, or your community, you know, rallies to have you removed, it becomes unfortunate. And we have seen that with some services that have either been politically moved out or moved out by the community that it served and that it was there for. So it's a common issue. And then I did want to touch also on Tanya's question on outreach in the rural. And as I forget what I do for my day job with Professional Counseling Center, the state has started to expand in-home SUD-based services for families involved with child protective services or foster care. And that is a program that I currently supervise, where we go throughout all of the thumb into some of the very rural areas. So again, taking that barrier, the family may not be able to get the treatment. So why don't we send the treatment to the family? If it's telehealth, if it's putting clinicians in cars, if it's what, we need to get that out there. Right now, there's only a handful of counties, 2 providers that are providing that service. So it's still very new for the state, but hopefully something like that will continue to expand to other counties in our state.
And a big piece of this may be the resource, the referral networks, building referral networks, which is another project that we're working on, in that a lot of medical service providers and emergency care providers are not fully aware. There might be a problem recognizing when people need referrals, but even when they do, getting people to referrals, know who to refer to, and that, you know, just telling people you need to see someone is not going to be sufficient, that they need more support in terms of transition levels of care, whether it's emergency services in the ER, short-term therapy, long-term, maybe they need detox or inpatient, what have you. And a lot of times the first responders, the first line source of contact when someone is in distress, are not well equipped to help people get into the system.
And I haven't seen any more questions come in, but we appreciate everyone that has joined us this afternoon. You know, that has taken their time to learn more about what we've done. And then I believe Christy can probably close us out.
Yes, I want to just thank you all for your time today, for bringing this information to us. It's all very interesting and important. And thank you all for attending this session. We hope you found the information shared valuable. Today's presentation is one of many webinars scheduled throughout the month of September. To see information and register for additional sessions, please visit our website at www.sccmh.org. Before we wrap up, we would greatly appreciate your feedback on today's session. A survey will pop up on your screen shortly, and we kindly ask that you take a few minutes to complete it. Your input is crucial in helping us improve future events and better meet your needs. For those of you that are requesting professional credits, please allow 2 to 3 weeks after the summit has concluded, and your certificate will be emailed to you. Thanks again for joining us today. We look forward to seeing you next time. Thank you all.